have in a perfect world is that an FSP team would have housing subsidy. So in other words, you have on these FSP teams, we are trying to address the social determinants. So what that means is, yes, there needs to be a housing specialist, and there needs to be an occupational therapist, or someone that does supported employment. But how about adding a housing subsidy and maybe a job? In other words, we can theoretically, I believe, and this is a pilot, tell the FSP teams, you have so many, you have money to actually subsidize housing for the people that you're caring for. So, which actually can be an incentive and can facilitate their access to a place to live, as opposed to kind of falling into the CES and not having kind of the extra support that's needed. Very, very excited about that, because I think if you can imagine, not everybody that's in FSP, but you can imagine that particularly as we move to take on more and more vulnerable people, and we get more and more engaged in folks who have criminal justice involvement, you have to bring housing with the team. There's a 24/7, 365 availability of services, but there also needs to be the demand that they have a place to live, or else you can't really provide the care. Yes?
I wanted to ask you, when you mentioned jobs, do we consider that to be a job of the Department of Mental Health? Because obviously getting a job could be the cure-all for anybody who's living on the street. But we don't have jobs. I mean, we're losing jobs every day, whatever the president says. Don't listen to him.
No, it's a great question, and I would say, first of all, it's not about jobs. It's about purposeful activity in life. It's about meaning in life and things that you engage that make you want to be well. Of course, it's nice to be employed and to be doing something that you love and care about and are passionate about, which is fulfilling, and also, especially if it's generative and it can create income that you can use to take care of your bills. We're not saying that the Department of Mental Health is necessarily at this point going to pay people to do work, although, I mean, if that's what it would take, I'm not in principle against that. I mean, I even said that I thought that we could consider using prevention money as a way to engage people and keep them engaged by giving them things to do, which would be productive and meaningful and helpful to their recovery. But what we are doing, and this is another thing, I mean, there's the January, I don't mean to build up the January summit too much, but by January I'm also going to be able to announce a number of new positions, and we'll be able to look at a very high level organizational chart that I can go through with everybody, recognizing that the organizational chart, which has got about 6,000 positions, has not been fully blessed by the CEO. Actually, the CEO is ready to sign off on it. I'm not. And I'm not because it doesn't have the things that we need and that I want for the department. So let's just say there's a little bit of an exchange going on there, and it has been for a while, and we will figure out how to settle it, but we're not going to settle for things that are not adequate. This department in many ways has been neglected. The positions are too low, and we don't have enough of them. So we're trying to elevate it. I mean, everywhere you look, it's like mental health this, mental health that. Oh, that's mental health problem. Okay, well, give us the resources and elevate us as an entity. Give us the best people, let us recruit the best people and drive this thing. So that's that. But I will touch on that, and the reason I'm bringing it up is that we're gonna go after purpose and jobs in an entirely new way. And there's a new deputy job that will focus exclusively on inventory of housing and inventory of employment all day long. I don't want to have a smattering of working with employers and the American job centers. We need to be going after that. We need to be going after grants. We need to bring it. We need to make sure that people, when we can engage them, and then sometimes we can use employment opportunities to engage people on the front side. That has to be a part of our armamentarium. It's not about treating people and looking at people as victims. People need opportunities to flourish. And they're not gonna get them unless we put them out there. It's not just services, it's opportunities, and we're investing in that. Oh boy, I'm getting a hook. We didn't even get through the first page. I'm sorry, I can't help it.
We'll just incorporate what's remaining into the January
All right.
discussion.
I mean, if you bring me down here to talk to people that we're here to serve, I'm gonna pour my heart out. I can't help it. Okay, homeless outreach and mobile engagement teams. The Department of Mental Health has had outreach teams for a long time. I think historically people would probably be most familiar with the bright green shirted SB 82 teams. Well, that was always very confusing to me because SB 82 is a Senate bill, and the Senate bill had a lot of different things, including money that was going to revert to the state that we're converting into crisis residential treatment programs across our healthcare campuses. But back to the SB 82 teams, they and our home team, historically, were doing very, very difficult work. And I'm not going to claim for a minute that engaging people who are in the streets is easy. But I am going to say that we, as a department, need to leave our mark by going after our mission, which is to take care of the sickest people who are suffering from serious, persistent mental illness and comorbid addictions. That it's not about meeting medical necessity criteria. I mean, you've heard me say this before. And our team, so you have like this broad set of outreach and engagement teams across departments with LASA, tons and tons of incredible community-based organizations. But we can't go after it that way. We have to be more disciplined and strategic. And we have to leverage our resources to take care of the folks that no one else is going to take care of. Okay? So the home team, there's a new position for the home team. Another deputy position, and it's not just for the home team, it's for what I call the engagement services. And again, I'll just give you a little foreshadow of January. So it's the home team, it's the outreach and engagement, it's AOT, it's our men's and women's reintegration programs, it's a whole person care, it's the veteran program that's going to be developed, which will basically be a part of the home program to go specifically to bring hire veterans to come out and do the work, who are incredible service members and are particularly adept at engaging their brothers and sisters and who may not want to really deal with others. But that program will be going after very specifically the most vulnerable populations. And we're taking what was once called SB 82 and then at one point was renamed HST, the Homeless Services Team, and the Home Team, and saying to the rest of the world, which means Housing for Health and the Homeless Initiative and the E6 movement and the CES, et cetera, et cetera, et cetera, that we're going to go after specialty outreach and engagement. And that we have to step up to take responsibility of that group. And we're not going to be satisfied by finding people that can meet medical necessity criteria and saying, oh, that's a person and that's a person that's less difficult, so we'll engage them. We'll try. Now listen, this is not easy work, and this is really cultural. There's a lot of cultural change here. And I'm just trying in this role to do what I think we as a department have to do as a part of the collective to solve the epidemics that we face. My own staff look at me sometimes and they wonder whether I'm serious, and then same with contractors, and they do that because this is not easy. It's not easy, and it may be that we're not able to house as many people as quickly because it's more difficult to house them, and it may cost more money per person to get them into a setting where they can be stable and have an opportunity to recover. But I don't care. I mean, that's why we're here. And that's a change. And the home team is emblematic. The home team is going to be out across this county. I think we have about 150 staff right now working with people doing what I call relentless engagement. I work with the home team. When I'm out in the street, which I do once a month, on the first Monday of the month. That's what I'm doing. We're going to bring in the doc who's going to try to work some medications with an individual who is not engaged. And the person that's not engaged can die in the street, can get picked up by the police, can, hurt themselves. We can't allow that. Housing assistance program. I'm already over my 10 minutes.
I wonder if maybe
Okay,
I could
Curly's
just provide
over here with
an
a
overview
stopwatch.
of this one thing, and then maybe we'll just move to questions from the commission. And if the public has any comments, you can stuff them in the box that we have, but also drop them to any commission staff like Daniel, who's right in the back and raising his hand. So if you have a comment card, direct it to him.
Madam Chair, can I recommend that doctor spend a few minutes on the third page, the development?
Yes.
So the capital improvements, just so that we've heard, we could spend the whole day on programs, and I love this, it's fascinating, but the capital improvement portion, I think, is an important piece.
Thank you, Mike. And I will say that HAP, which is the last one on that page, just to finish off the page, that's just like paying for stuff that people need. And you can read about it, and we have that distributed through a number of programs, and I want to figure out how to consolidate. Capital investments. What we have here actually is the investment that we've made to present since 2008. But I don't know what it was before I got here. I think it was somewhere in the 150 to 170 million range. Does that sound about right? You don't know. Anybody know? It's somewhere under 200. We have invested 150 million in CSS dollars alone, plus in the past 2 years. Plus, we're now bringing in the No Place Like Home money, which is substantial. Although, as you heard, and again, it's not about making friends. The developers are great people, and we need developers. And when I say that I think we need to invest in the infrastructure that exists because we can get stuff cheaper and faster in addition to building new inventory, that's not always a popular thing to say. But No Place Like Home, hopefully, in future years, will allow for that. The mental health housing program, I think everybody's familiar with that. That's really kind of the nuts and bolts of us using CSS dollars to invest in permanent supportive housing. HMIOT is just kind of a random grant that we happen to get a hold of, the Departments of Health, Mental Health, and Public Health, year and a half ago. I think it was for, I thought it was for 40. Yeah, it was for 40 million. I think we got 15 of it. And we're using that to do interim housing. And we're looking at it, one in each of the supervisorial districts at a minimum. The special needs housing program, oh, there it is. There's that number. This is what predates me. When I showed up, we were using MHSA dollars for housing, and we were sending the money back to the state to Cal HFA, and then Cal HFA was acting as our CDC, also now known as LACTA or CDA, to run the NOFAs and to oversee the developments. So the before I got here was the 155. One of the things that I'm trying to figure out is how we, as a department, with investments like this, are weaving our resource and leveraging other resources, whether it's kind of tax incentives for developers, whether it's Triple H money, whether it's Measure H money, whether it's going to be new money coming from the state, because the state, I don't know what the governor put in, like $2 billion for housing or something, big number. But the thing is that those are technical questions, and they're sometimes hard to figure out. But what I really, really want to do is I want to make sure that the money that we're using that comes through this department, that is pushed out and sometimes is weaved and leveraged, is leveraged for people who are most vulnerable. that have serious mental illness and many times comorbid addictions. That's my commitment, and I'm telling you that that's really not an easy thing to do.
Okay, thank you very, very much. We heard a lot of philosophy and some program specifics that we probably didn't all know by heart, so thank you very much. And I wonder if the commissioners have any questions specifically to the programs that were discussed or the numbers on this chart. And I would say this is not going to be our only opportunity to discuss this, because we'll expect more presentation on budget in January. Also, we have Maria Funk from the department presenting on housing and board and cares in December. So we'll have more discussion on this. Commissioner Friedman.
I just have a very, very quick thing to say, and that is I read the other day, and I don't know if this is true, that there are 3 city councilmen who are now supporting a move in the city council to have the mayor pick the places in the city where homeless housing will be put. So no more NIMBYism. He's got to put his political career and everything else he's thinking about on the line, pick these places, and it would be very, very terrific if all of you people went to the city council meeting when that comes up to support it, because it's going to be all the NIMBY people there screaming and yelling. We don't want that.
I see this as a problem you have to approach from both ends, because at the end we have people that have just been homeless for so long, they have so many needs. It's a bigger challenge, and people are far more negative about them. But we have that, I think it's around 20%, the recent study said, that are newly homeless. And if we can get to them now, in 3 or 5 years, they're going to be chronically homeless. So do you have a plan for that part too?
Yeah, I mean, I think the county in general is putting a lot of resource towards homeless prevention. And what I would say to you, Keita, is that, and I've said this to the supervisors and to my counterparts, we need to treat homelessness and risk of homelessness in particular as a vital sign. That, if someone comes in with a blood pressure of about 200 over 130, we pay attention, because they have a very good chance of having a cardiac event or having a stroke. And if we look at, and that's because it's a vital sign, and every time you go to the doctor, you get a vital sign. You go to the doctor and you go to a clinic where you're at risk. We have to figure out solutions. The question would be what monies to use. Now, I would suggest for certain that if it's a client with serious persistent mental illness that we're engaging with, we all day ought to be funding and making sure that we keep them in their housing, even if they haven't been homeless. But many people who fall into homelessness, I think, deteriorate in every way, physically, emotionally, and spiritually, from being homeless. And what I would say is that we have a certain amount of resource. The county as a whole has resource that it's throwing at the homeless challenge. And I would ask the other departments in the homeless initiative to focus on people who don't have serious mental illness and or comorbid addictions, and prevent them from falling out of homelessness with resources that are not core mental health funds.
Okay.
You're not satisfied with that answer?
I'm just thinking, who are they and where is it going to come from? And when you start talking about traumatic events and kids and everything, it's hard to believe that you don't need, there shouldn't be prevention funds, at least for the families that are homeless.
Well, I think there are a lot of prevention funds through the homeless initiative, and they're supposed to be being used for, I think, what you're describing and what I'm trying to come back to you with. And people who are on the street, look, we have really horrendous conditions. We have tons and tons of people suffering trauma and repeat trauma, chronic trauma all over. How do you go after it? I'm trying to move this department towards one where where our North Star are the people who have the most severe illness. And preventing people who are in communities from developing illness by identifying them early and bringing them into care. The issue of homelessness and people falling into homelessness actually in many cases is kind of initially not driven at all by a medical condition or mental illness. These are major societal factors. And I'm not gonna, given the fact that we have a certain amount of budget, I'm not gonna exhaust the budget on that. I'm gonna ask other people to do that.
Go for it.
I'm trying.
Okay, one more question.
Thank you. Doctor, it's so encouraging and refreshing to hear a general manager willing and ready to take on a restructuring and working with the CEO's office to make that happen. That's fantastic. Every department really needs to go through that kind of internal review and determining what positions are best suited and how the organizational chart eventually looks like. And again, commendable that you're trying to bring in new senior positions for some key areas. You mentioned earlier something that piqued my curiosity is one of those senior positions would be looking at the ability to seek out new revenue through grants, whether it's on the state or the federal side, and I think that's really, really good. It seems to me that that's what you need, and that's a portion of what you need. Is in that restructuring also a look at how you have within your staff or through other advocates ways to work with the state legislature and the governor's office as well as federal agencies to seek out new dollars? And attached to that, once you get the new dollars, like the governor puts X billion dollars in, do you have folks internally that know how to tap that money and get to those sources? I know I work for public agencies that it's great to get this X million dollars, but then how do you really get it? So I'm just curious if your reorganization or your restructuring is looking at those areas too.
Well, the restructuring, which is really, I'm gonna say, at least as someone who's working in bureaucracy, has been traumatic. It's been traumatic for me. It's been traumatic for the staff. It's been traumatic for a lot of folks. But boy, is it long overdue. I think the reason why it's so difficult, it is so overdue. I cannot tell you how fragmented this organization is.
Thanks for your honesty there. That's great.
Well, you gotta try to be transparent and bring people along. This is a team sport. And I mentioned a couple of positions. We've reorganized. We're reorganizing the entire administrative side of the house. To do a lot of different things. And I have a team that I'm working with and actually a consultant in Sacramento who are driving a lot of the, frankly, a lot of the policy. We got off on this, you probably heard this a million times and I'm gonna say it until I either, retire someday or croak. But when I showed up, I was 6 months into my first year. And there were that within 4 months we would revert $225 million, and we went after that. I went after that. So what I'll tell you is that our presence, and I did that by going after all the key players. I went to the board to get them to ratify it. I went to the CEO and their legislative affairs. I went to the Oversight and Accountability Commission. I went to several key legislators. I went to the governor's office. And said, don't take this money back. We need this money. And that $225 million is a lot of the, I said we bumped it up to 709. Well, a lot of that's the 225 because we saved it to prime pumps. So we, in terms of being able to go after the money and then to bring the money in and to expend it, I think it's a new era right now. But, it's early. These things take a long, long time. We have to, and it's always a work in progress. So while at the same time that we're trying to create a stronger administrative structure, we're also reorganizing all of our clinical services, and we're going to learn in the process of doing that, and it just requires a lot of tolerance. And I've apologized openly to my staff that it's taken so long. I had no idea it was going to be this difficult, but I wasn't told what I had. Just like I wasn't told I had $225 million that was going back, I wasn't told about how the department was really structured properly. And so it's, this is a long, painful process.
Okay, Commissioner Acebo came in very late. Do you have a final comment for Dr. Sherin?
John, good to meet you, and thanks for